Hey everyone, and welcome back. This is the deep dive, and this one's specifically for Professor Segi's abnormal psychology students at LACC, tackling Module 7.
Yeah, we know you're digging into some really challenging stuff right now
Mm,
and doing it while navigating, everything that comes with being young in LA. The stress, the ambition,
exactly. The relationships, figuring out who you are. It's intense.
totally. And that's honestly why this module, looking at eating, feeding, and sleep-wake disorders, is so incredibly relevant. It's not just about clinical diagnoses for some future job.
Right. It's kind of about understanding the pressures and vulnerabilities we all face, maybe even in ourselves.
Precisely. It's a deep dive into understanding human complexity.
So our mission today is to move beyond just the definitions in the module and really get into the insights, both clinical and personal. Let's start at the very beginning. The biology. How does our body even know when it's hungry or full?
It's this really elegant back and forth system. Your brain, specifically the hypothalamus and the hindbrain, they're like the control center. Hunger cues are pretty straightforward.
Like stomach growling, low blood sugar.
Exactly. Stomach contractions, sensing that dip in blood glucose. But
Mhm.
telling your body to stop eating satiety, that's actually more complex.
Okay. How so?
Well, you've got rising blood glucose levels, sure, but a really critical player is a hormone called leptin.
Ah, leptin. I remember reading that's secreted by fat cells.
You got it. It essentially sends a message to the brain saying, hey, we've got sufficient energy stores down here. You can ease up on the intake. So the brain's constantly weighing these signals.
Fascinating. So it's this internal balancing act.
It is. And the biological regulation leads us straight into a really key and sometimes frustrating concept from the module, body weight regulation. We all know calories in, calories out matters, but
But biology throws a curveball.
a big one. It's
Yeah.
called the set point theory.
That's the idea that our bodies have a sort of pre-programmed weight range they like to stick to, right? Like an internal thermostat.
That's a great way to put it. It suggests there's a genetically influenced weight or range that your body actively defends.
So if you try to lose weight drastically,
Your body often fights back. It doesn't care about your summer plans. It perceives a potential famine and adjusts your metabolism to conserve energy, trying to push you back to that set point.
which explains why long-term sustainable weight loss can be so incredibly difficult. Biology versus willpower.
It's a major factor, absolutely. Now, speaking of weight, this module uses the body mass index, BMI, to define obesity, a score over 30. But we have to talk about the criticism.
Yeah, especially for LA folks who might be really into fitness, lifting weights. BMI doesn't account for muscle mass, does it?
It doesn't. And that's a huge limitation for assessing an individual's health risk.
Hmm.
Someone could have a high BMI purely because they have a lot of muscle.
So why is it still the standard definition in the module?
That's a really important question. The reason is utility, essentially. While it's not great for individuals, especially athletic ones, it's still statistically useful for tracking health trends across very large populations.
Okay, so clinically, you note the BMI, but you have to use critical thinking, look at the whole person.
Absolutely. You have to consider body composition, lifestyle, other health markers. BMI is a starting point, not the whole story.
Good point. Let's pivot now to the core eating disorders, starting with anorexia nervosa, or AN.
Right. AN has three core features you really need to grasp. First, significantly low body weight, often dangerously so. Second, this intense, overwhelming fear of gaining weight or becoming fat.
Even when they're already underweight.
Exactly. And third, this is crucial, a distorted body image. They genuinely perceive themselves differently than they objectively are.
And the behaviors we see, like extreme food restrictions, starvation, maybe excessive exercise, stem from that fear and distortion.
Precisely. And this module rightly emphasizes the huge role of sociocultural factors.
Which feels incredibly relevant here in LA with the constant media focus on thinness, perfection.
It's a massive pressure cooker. That cultural emphasis can act like fuel on the fire for someone vulnerable. Treating AN means battling biology, the deep-seated psychological distortion, and these powerful cultural messages all at once.
So treatment has to be comprehensive.
Definitely. You need nutritional rehabilitation to restore weight safely. You need cognitive behavioral therapy, CBT, to target those distorted thoughts about weight and shape. And often, especially for adolescents, family-based approaches like the Maudsley method are really effective.
Okay. If AN is about rigid restriction and control, how does bulimia nervosa, BN, differ?
The key difference in BN is the cycle. It involves recurrent episodes of binge eating, eating a very large amount of food in a short time, feeling totally out of control while doing it,
And then,
and then engaging in compensatory behaviors to try and prevent weight gain. This is the purging aspect. Self-induced vomiting is common, but it can also be misuse of laxatives, diuretics, or excessive exercise.
the physical toll sounds immediate.
Oh, it's rough. Chronic sore throat, dental erosion from stomach acid, serious gastrointestinal problems, dehydration, dangerous electrolyte imbalances. It's physically damaging.
And psychologically.
High comorbidity.
Hmm.
DN often goes hand in hand with anxiety disorders, depression, sometimes substance use issues. You're often treating multiple things at once.
Then there's the third major one, binge eating disorder, or BED. How does that fit in?
BED involves those same recurrent episodes of binge eating with that feeling of loss of control, just like in bulimia.
Okay.
But, and this is the critical distinction, there are no regular compensatory behaviors afterward. No purging, no excessive exercise, specifically to counteract the binge.
So the result is often weight gain.
Yes, BED is frequently associated with being overweight or obese, and it's actually becoming the most common eating disorder.
Wow. And for treating both BN and BED, what does the module suggest works best?
For both, psychotherapy is really central. CBT is, again, a gold standard, helping change those patterns of thinking and behavior around food and eating. Interpersonal therapy can also be effective.
What about medication?
Sometimes, yes, SSRIs, the antidepressants, are often used particularly for bulimia and sometimes for BED. They can help reduce the frequency of binges and address some of the underlying mood or anxiety issues that often accompany these disorders. Usually it's a combination of therapy and potentially medication.
Okay, that covers the big three eating disorders often driven by body image concerns, but the module expands beyond that into feeding disorders. These seem different. Let's start with ARFI.
Right, ARFA, avoidant restrictive food intake disorder. This is a really important one because the driving force isn't fear of gaining weight or body dissatisfaction.
So what is the issue?
The person avoids or restricts food for other reasons. It could be a profound lack of interest in eating, or, very commonly, avoidance based on the sensory characteristics of food. The texture, the smell, the temperature just feels intolerable.
Like extreme picky eating, but way beyond that.
Exactly. Or it could stem from a fear of negative consequences associated with eating, like a past experience of choking, or a fear of vomiting that's called emetophobia.
But the outcome is still serious. Malnutrition, weight loss.
Absolutely. It can lead to significant nutritional deficiencies, failure to gain weight or grow properly in kids, and major problems in daily functioning because eating is so difficult.
How do you even treat something like sensory avoidance?
It requires a really specialized approach. Nutritional counseling is key, obviously. CBT can help manage the anxiety or phobic aspects. And sometimes therapists use systematic desensitization, very gradually and carefully exposing the person to the textures, smells, or tastes they find aversive in a safe setting.
That sounds challenging. Okay, moving on, the module also mentions rumination disorder and pica. These sound quite unusual.
They are less common, but important to know. Rumination disorder involves repeatedly regurgitating food shortly after swallowing it. The person might then re-chew it, re-swallow it, or spit it out.
And this happens consistently.
Yes, typically within minutes after eating. It's not like vomiting due to nausea. It seems more habitual or involuntary for some. Obviously, it can lead to malnutrition, dental problems, social isolation.
And pica.
Pica is the persistent eating of non-nutritive, non-food substances. Things like dirt, clay, chalk, paper, paint chips, hair, ice.
Ice. Really?
Yes, compulsive ice eating, pagophagia, can be a form of pica, often linked to iron deficiency. But eating things like paint chips or soil is incredibly dangerous.
Because of toxicity, blockages.
Both lead poisoning from paint chips, parasitic infections from soil, intestinal blockages. It can be a medical emergency. It's seen more often in young children and sometimes during pregnancy, but also in individuals with intellectual disabilities. Immediate medical evaluation is crucial.
Definitely highlights the serious physical risks. Okay, let's shift gears significantly now to the third major section of this module, sleep-wake disorders. This feels incredibly relevant for college students.
Oh, absolutely. Balancing LACC classes, maybe work, social life, family. Sleep often takes a back seat, right?
Yeah.
But it's fundamental.
So let's start with the basics from the module. Sleep structure, REM and NREM.
Right. We cycle through different stages. NREM, or non-rapid eye movement sleep, has 3 stages, getting progressively deeper. Stage 3 is that really deep, slow wave sleep.
That's where we see those specific brain waves, like delta waves.
Exactly. Big, slow delta waves dominate stage 3 NREM sleep. This is the really restorative stage, crucial for physical repair, growth hormone release, and feeling rested.
And then there's REM sleep.
Yep, rapid eye movement sleep. Brain activity looks surprisingly similar to wakefulness. Very active. Your eyes dart around, breathing and heart rate can become irregular. This is when most vivid dreaming happens. Your body is essentially paralyzed during REM, probably to stop you acting out your dreams.
Okay, so understanding that cycle helps us understand the disorders. Let's talk about the most common ones students probably experience. Insomnia.
Ah, yes. Insomnia. It's not just tossing and turning for one night because you have a big exam.
Right, the module defines it pretty strictly.
It does. It's persistent trouble falling asleep, staying asleep, or waking up way too early and not being able to get back to sleep. And crucially, this has to happen at least 3 nights a week for at least 3 months and cause significant distress or impairment in your daily life.
What causes it? Especially thinking about the LA student context.
Multiple factors. High stress reactivity is a big one, just being more sensitive to stress. Anxiety, definitely worrying about classes, future finances, environmental factors, noisy apartment, inconsistent schedule. And there's a genetic component too.
So what works for treating it, beyond just popping a sleeping pill?
Well, sleep aids pharmacotherapy can help short-term, but the gold standard, long-term, is non-drug. Cognitive behavioral therapy for insomnia or CBTI is highly effective.
What does that involve?
It tackles the maladaptive thoughts and beliefs about sleep, like catastrophizing about not sleeping, and it includes powerful behavioral interventions to basically retrain your body and brain for sleep.
Interesting. Now, let's move to disorders where people sleep too much or at the wrong times. Narcolepsy sounds quite dramatic.
It can be. Narcolepsy involves excessive daytime sleepiness, these uncontrollable urges to sleep, sometimes called sleep attacks, happening at really inappropriate times.
And isn't there something else associated with it? Cataplexy.
Yes, that's a key feature for many, though not all, with narcolepsy. Cataplexy is a sudden, brief loss of voluntary muscle tone, usually triggered by strong emotions like laughter, surprise, or anger.
So you could just collapse.
Sort of. Your knees might buckle, your head could drop, jaw goes slack. It's like the muscle paralysis of REM sleep intruding into wakefulness. It's not fainting. The person is conscious.
Wow. Okay, what about hypersomnolence disorder?
This is also about excessive daytime sleepiness, but it's different from narcolepsy. People with hypersomnolence feel excessively sleepy despite getting what should be enough sleep, like 7 hours or more main sleep, maybe even sleeping 9 or 10 hours and still feeling tired.
And they struggle to wake up.
Big time. That's often called sleep inertia or sleep drunkenness. Really profound grogginess, confusion, difficulty becoming fully alert for sometimes hours after waking up. It causes significant impairment.
Then there are the parasomnias. What falls into that category?
Parasomnias are basically undesirable things that happen during sleep or during the transition between sleep and wakefulness. They involve abnormal movements, behaviors, emotions, perceptions.
Like sleepwalking.
Sleepwalking, yes. Also sleep terrors, episodes of intense fear, screaming, maybe thrashing around, usually during deep NREM sleep. The person is hard to wake and usually doesn't remember it. Different from nightmare disorder, which involves scary dreams during REM sleep that you do remember.
What else?
Restless leg syndrome often gets grouped here too. That uncomfortable urge to move your legs, usually worse in the evening or at night, disrupting sleep onset.
Okay. And finally, a really serious physical one, sleep apnea.
Extremely important. Apnea means cessation of breath. So sleep apnea involves repeated episodes where breathing actually stops or becomes very shallow during sleep.
How long do these pauses last?
Can be 10 seconds, sometimes much longer. The brain senses the lack of oxygen and briefly rouses the person, often without them fully waking up to restart breathing. But this happens over and over, fragmenting sleep terribly.
Leading to exhaustion the next day.
Severe daytime fatigue, yes. Also headaches, irritability, and serious long-term health risks, high blood pressure, heart disease, stroke.
The module mentions 2 main types.
Right. Obstructive sleep apnea, OSA, is the most common. The airway physically collapses or gets blocked during sleep, usually by relaxed throat tissues. Central sleep apnea, CSA, is less common. The brain basically fails to send the proper signals to the muscles that control breathing.
And the treatment. I feel like I see people using those machines.
The CPAP machine, yes. Continuous positive airway pressure. It delivers pressurized air through a mask to keep the airway open. It's the primary treatment for moderate to severe OSA. Lifestyle changes like weight loss can help too, sometimes dental appliances or even surgery in some cases.
Okay, we've covered a huge amount of ground, the disorders themselves. Now, section 4 in the module talks about perspectives, applying this knowledge. Why is it so critical for you as future clinicians to see these issues through multiple lenses?
Because people are complex. No single perspective captures the whole picture. Take eating disorders. The biological lens points us to genetics, neurotransmitters like serotonin, the HPA axis stress response, guiding potential medication targets.
And the cognitive view.
That focuses on the thinking. The bias is how someone with the AN might only pay attention to information confirming their fear of fatness. CBT directly targets these distorted thoughts and intentional biases.
Then behavioral looks at learned patterns.
Exactly. How dieting behaviors might be initially reinforced by praise or weight loss, then become entrenched. Behavioral therapies use techniques like exposure, maybe gradually reintroducing feared foods.
And we can't forget sociocultural.
Absolutely essential, especially here. Our media, cultural ideals of thinness, family dynamics, how they create pressure and contribute to risk. Therapy has to acknowledge and address this context.
Finally, psychodynamic or humanistic views.
They encourage looking deeper at unconscious conflicts, issues of self-worth, identity, or maybe how the disorder serves some function in managing difficult emotions or relationships. It adds another layer of understanding.
And we apply this multi-lens approach to sleep disorders too.
Definitely. Biologically, we have treatments like CPAP for apnea, medications for narcolepsy or insomnia, very concrete interventions.
Cognitively.
That's about changing the relationship with sleep and wakefulness. CBTI, as we mentioned, alters anxious thoughts about sleep. Mindfulness helps reduce that pre-sleep arousal. Sometimes paradoxical intention trying not to sleep can weirdly reduce anxiety and allow sleep.
And behaviorally, you mentioned some powerful techniques for insomnia.
Yes, things like stimulus control. This is about reassociating your bed only with sleep and intimacy. No reading, watching TV, worrying in bed. If you can't sleep, you get out of bed. It strengthens that bed-sleep connection.
Sounds strict.
It can be. And sleep restriction is another powerful one. You actually limit the time spent in bed to roughly the amount of time you're currently sleeping, even if it's only, say, 5 hours. This builds up sleep drive, makes sleep more consolidated, and then you gradually extend the time in bed.
Wow, so you intentionally sleep deprive someone temporarily.
In a very controlled way, yes, to improve sleep efficiency and quality long term. It requires commitment, but can be very effective.
And just briefly, any psychodynamic take on sleep?
Historically, psychodynamic therapy focused a lot on dream interpretation, seeing dreams as windows into the unconscious. While less central now for treating the disorders themselves, understanding how early experiences or unresolved conflicts might manifest in sleep disturbances can still be relevant for some individuals.
Okay. Professor Sagi's students, we know this module has taken you through some really deep and sensitive territory, from the biochemistry of leptin to the practicalities of CPAP machines. It's a lot.
It really is.
Yeah.
And studying these disorders, understanding the vulnerability they represent, it takes empathy. It's tough material, but grasping it is a huge step towards becoming an effective, compassionate professional.
It truly is about translating the science into understanding real human struggle.
Exactly.
So, as you wrap up your work on Module 7, we want to leave you with a final thought to chew on, something connecting back to your lives here in LA. We talked about the body's biological set point for weight and how behavioral sleep treatments often require really strict control, like stimulus control.
Right. So consider this. In your own busy, ambitious life here, juggling school, work, everything else, how much of your daily rhythm, your eating patterns, your sleep schedule is genuinely driven by your internal biological needs versus how much is shaped by external pressures? Cultural standards, social media, your own drive to achieve.
Where's the balance between your body's signals and the demands of the world, or the demands you place on yourself, that tension? That's something to really think about.
It's at the heart of so much we study in abnormal psychology. Keep exploring these questions. Good luck with the rest of the course.
We're genuinely excited for you to continue this learning journey.